Great. Thanks so much,
Can
Jenny.
everyone see that? Yes? Okay, perfect.
Perfect. All right, great. So without further ado, thanks Kelly and everyone and the committee for organizing this. Thanks for the kind introduction, Jenny, and helping me with that technical issue. I guess this wouldn't be without some tech issues, but perfect. Glad everyone's here. Thrilled to talk about cultural considerations in early psychosis care, which an issue, early psychosis, that primarily affects youth. So I think it's really aligned with this conference and really passionate about this topic. So very excited to present today. And Jenny, you can go to the next slide, please. Great. And you can, there are some animations, so you can just play out perfect. So just some background on me. So as Jenny said, I'm a clinical psychologist by training and current postdoctoral fellow. And I primarily work with people in the early stages of psychosis, mostly adolescents and young adults at the Mount Sinai School of Medicine here in beautiful Manhattan. Also conduct research on psychosis, help with training, and really passionate overall about mental health education. So doing trainings like this and dispelling myths about psychosis and letting people know more about practical tools. How can we assess for psychosis? How can we treat psychosis? And with that, I'm really passionate about stigma reduction as well. So dispelling, increasing knowledge about psychosis. And last but not least, bridging that gap between research and clinical care, because we know that there are so many good treatments and assessment tools out there for early psychosis, but not many people are aware of them or use them. So I hope to share some of that today from a culturally sensitive perspective, which we certainly need in the mental health field, especially for psychosis. So great. Jenny, you can go to the next slide, please. So this is an agenda for today, and these are aligned with the objectives for this talk. So we'll start by defining the issue of psychosis, early psychosis, the different phases, culture, intersectionality, in related terms. And again, I'm hoping to sort of dive into a few areas, leave you with some information, and most importantly, I think some practical tools that you can bring into your work and or share with others. So Jenny, you can go to the next slide, please. We'll start with defining the issue. Great. And we'll go to the next slide and talk about psychosis big picture for a minute. So this may be a review. But approximately 1 to 3% of people develop a psychotic disorder in their lifetime. And you can great. And we know that that means about 100,000 adolescents and young adults in the US are developing a first episode of psychosis each year. And we'll talk more about what that looks like. There's a huge estimated economic burden for psychotic disorders. And this is related to direct healthcare costs, indirect costs related to unemployment factors. But we know that there's a huge human and individual and family impact related to psychosis, including an early mortality rate, lower quality of life on average. But we know that these things can be mitigated with early intervention, and especially early intervention that is culturally sensitive. That will be most effective. So you can play out the rest here, please, Jenny. And whenever I do this presentation, I want to make sure that we destigmatize the narrative, because we know that psychosis is one of the most stigmatized mental cluster of symptoms. But we also know that with treatment, like I said, many people can indeed recover from psychotic experiences. And in fact, there's a whole area of research on something called post-traumatic growth, where people who have experienced early psychosis find meaning from these experiences and talk about their resilience and their spiritual growth. And there's still so much more we need to learn about psychosis. So you can go to the next slide, please, Ginny. And when we talk about psychosis, this is not a diagnosis, right? You're not going to see psychosis in the DSM. It's rather an umbrella of a cluster of symptoms and experiences. And these are diverse experiences ranging from things like a loss of touch from reality. You might think of classic symptoms like hallucinations, delusions. And these are commonly associated with schizophrenia spectrum disorders like schizophrenia, schizoaffective, but they can be present across a range of disorders, including mood disorders, people who experience trauma or PTSD, people who use substances. And if you could play out the last part of this slide, please, Jenny. Great. And when I say early stage psychosis, we're talking about the first signs and experiences of psychosis among youth, right? The first onset of these experiences. And just to start bringing in culture a little more here, the DSM is pretty clear that, right, we're not going to diagnose a psychotic disorder if it's, let's say, a thought that it is explained by a culture, right? Some cultures believe in, superstitions or spirits, right? Or may see, loved ones after they pass away and have visions, right? If that is a shared belief, not psychosis, right? So we naturally need a cultural lens here all of the time. So next slide, please, Jenny. We're going to talk about the two main symptoms of psychosis, just real quick, a quick review here. So there are positive symptoms, right? These are the classic hallucinations and delusions, and you could play the animation to show that. I think it's one more, Jenny. People may have disorganized speech or behavior. And then we have negative symptoms, right? Which are behavioral deficits. People may experience social withdrawal, decreased motivation or activity, anhedonia, avolition, limited facial expression we might see, right? Maybe a flat or blunted affect. But typically, psychosis, we're looking for those positive symptoms happening alongside the negative symptoms, right? These negative symptoms sometimes can overlap, right, with depression and other things. So we want to do a good assessment. These clusters. Okay, next slide, please. And when we talk about early stage psychosis, we're talking about two main phases. So there's the psychosis risk period. And people can feel free to write in the chat if you've heard about these, because I'm always curious if people are familiar with like psychosis risk and first episode psychosis, or if you've worked with people experiencing this. So about this on the next slide in just a minute, but psychosis risk, has many terms. We have psychology and psychiatry always use all sorts of terms for the same thing. Our clinic, for example, that I work in, we call it clinical high risk for psychosis. You'll also see ultra high risk, prodrome. But these are essentially warning signs and subthreshold experiences. They do not meet the criteria for a psychotic disorder, but it's a risk state. And this is the area that I mostly work in right now. And I'm going to share some tools with you later on today best for this. And again, these resemble psychosis, but don't typically reach the same level of severity or frequency, and people can induce doubt here. But we know that these experiences can be a transdiagnostic risk factor for future mental health problems. And then first episode psychosis is when you first meet criteria for a DSM psychotic disorder, right? Okay, next slide, please. Okay, and you could play this out too. I think there are two more animations. I'm realizing I used a lot of animations with this. So this is a typical trajectory of someone who may develop a psychotic disorder. So we have a pre-morbid period, right? This is a period where someone maybe in childhood or early adolescence, not experiencing too many symptoms or any symptoms. And then there's this risk period, right? Or this clinical high risk period where these warning signs. And then some of those people, about 20 to 30%, may develop a psychotic disorder, right? Like schizophrenia, right? So it's important to think about this on a spectrum. Great, so you can go to the next slide, please. Great, yep, perfect. Okay, and who experiences early stage psychosis? As I said, this is the group of people that, right? These is youth, young adults, to high school to college, right, and beyond. And this is happening for folks during key developmental periods. Identity development is happening. People are forging peer relationships. People are figuring out what they want to do in the future. And these experiences can disrupt, that development. So we really need a culturally informed and a developmentally based lens whenever we're doing this work. Okay, so next slide, please, Jenny. This is just some sort of like textbook definition on culture, just as an introduction to this. So, we all have culture, right? I have culture. In terms of ethnicity, I come from an Italian and an English background. So I have certain, customs and, older relatives who have spoken different languages, celebrate certain holidays. But it's so much more than that, right? There are certain family structures, right? Religion, spirituality that can come up. We all have it. But it's important to recognize that people are exposed to multiple cultures. And even within certain cultures, right? Let's say the ethnicity of Italians or English people, that in itself is a diverse group of people, right? They're not all the same. So we need to be careful not to overgeneralize any cultural information whenever we're meeting with someone or to stereotype, right? We really want to find out that person's subjective experiences of, being part of that ethnicity or that racial group, or that religion or spirituality, or that gender identity. Really important to dig into that. So we go to the next slide, please. And this is important because we know that the US is becoming more and more diverse and globalized. So if you can go 2 animations forward, Ginny, I think we'll have some great, yeah, perfect. We know by 2045, non-Hispanic whites will actually make up half of all Americans and be in the minority compared to minority groups. So, I mean, more and more this country is becoming diverse, and we need culturally sensitive care, now more than ever. Next slide, please. And we know actually that this is happening for our youth. So 1 animation forward, please, Ginny, that'll highlight that far end, perfect. We know that right now, white youth under the age of actually 18, as of 2020, are in the minority, right? Among all people, young people now in the United States, there are more minority people than there are white young people. So more and more, right? That's just race and ethnicity. That's an important part of culture. So we need to make sure these services are accessible and are individualized to the diverse people coming to our services. Next slide, please. And just to sort of wrap up early stage psychosis importance, this is not a rare phenomena. It's actually more common than people think. So psychosis risk, for example, can happen in about 20 to 25% of clinical samples. That's a huge number, right? Like 1 in 5, 1 in 4 people who are at risk for psychosis. So not rare. And as noted, right, about 100,000 or more young people in the US developing a first episode of psychosis each year. And we know that early intervention, early treatment can be so effective for this group. So we really want to get in there early. And that last animation, please, Jenny. And we know, again, that these intervention efforts will be most effective and equitable if they're culturally responsive. Okay, next slide, please, Jenny. And there are a ton of, oh yeah, great, God. We know psychosis and culture are deeply intertwined, right? Social, environmental, cultural factors, all influence treatment and prognosis of psychosis. We know that there's a history of racism, unfortunately, in the mental health field, and that has, impacted how and who we have labeled with psychosis. And explanations of and beliefs about psychosis can differ cross-culturally, right? So we need to be aware of all of these things. Next slide, please. And there are a ton of animations here, Jenny, so you can go through all of them, and I'll go through them one by one. So we're going to talk about societal, environmental, and cultural factors on this next slide. So we know that there's a long history of culture being intertwined with psychosis, unfortunately. So sluggish schizophrenia was actually a diagnosis used in the USSR and Eastern Europe in the 60s and 70s to diagnose people who didn't agree with the people who were, politically in power. The World Health Organization and others actually consider this to be a form of political abuse. This also happened right here in the United States during the Civil Rights Movement. Black Americans were often diagnosed as having schizophrenia or some type of psychotic disorder when they wanted to protest, right, for civil rights. We know that there are differences in high and low income countries. In income countries and developing countries, people with schizophrenia actually tend to fare better. And some people think the collectivistic cultures that are typically found there, as well as maybe a less rigid way of life and easier for that individual to be incorporated into the community. We know that there are, research studies on urbanicity. If you grow up in a very urban environment in a developed country like the US, you may be at a higher risk for psychosis due to pollution, due to exposure to drugs or community violence. So many different factors to consider. And you could play out the rest of them here, Jenny, please. Neighborhood crime, right? All of these sorts of stressors, a culturative stress, which we'll talk about in a second. These are things that aren't unfortunately in psychosis assessments and when we're working with youth. So these are just some examples of things we can ask, sort of in terms of cultural background, community violence, right? What's your neighborhood like? What have your interactions with policemen, for example? What is your level of acculturation of your family's immigration experience? You can go to the last perfect. And then we know there's significant stigma, which I'll talk briefly about on the next slide, Jenny. Unfortunately, here in the US, there's still tremendous stigma toward people with psychosis, and this is actually rising. By 2018, over 60% of a general sample of people in the United States thought people with schizophrenia would be violent. And that number is disproportionate. We know that number is in the single digits and very low. We go to the next slide, please, Jenny. And we know that racism and other discrimination can also lead to psychotic experiences, right? So this race-based stress needs to be evaluated as well. And this is typically not evaluated in a standardized way. And to my knowledge, there are no interventions that directly target this for youth of color, for example, who have psychotic experiences. So these are other things we need to assess. And as I noted, there's this unfortunate history, which the American Psychiatric Association recently apologized for, of misdiagnosing and sometimes mislabeling people of color with psychotic disorder. So we need to be aware of that history as well, and maybe some mistrust of the institutions that we work in. Go to the next slide, please, Jenny. And like I said, there is a culturative stress too. So just real quick on this research, if you look on the right, those are the culturative stress items that were used in this research study. And it was found that people who endorsed more of those items, who had more stress acculturating to a new environment, they actually had higher rates of psychotic experiences, like hearing things that weren't there or seeing things that weren't there. So again, really important things to assess, again, especially as our country becomes more and more diverse, right? We need to ask people about stressors coming to this country, or stressors that their parents have had and how that has impacted them. And again, these are typically unasked questions in our evaluations. Can you go to the next slide, please, Jenny? There are going to be a ton of animations here because I apparently love animations. It becomes more apparent when someone else is doing a great job. When we talk about frameworks and cornerstones, there are some wonderful frameworks we can use to guide our clinical work. One of them is intersectionality. And I'd encourage, if there's anyone in the chat who wants to say, they're aware of this or they've used it in their work, feel free to let me know. I'd love to hear. This was developed by Kimberly Crenshaw in the late 80s. She is a lawyer, I believe, and a researcher. And she made the argument that people have intersectional identities. For example, right, you may be a Black woman, but you might be a Black woman who is maybe from a stigmatized sexual orientation, right? Or just being Black and a woman, right? Those could be two stigmatized identities. So we need to be aware of sort of the multiple oppressed identities that people may have and how this can impact mental health care, how people view themselves. And intersectionality has since been applied to multiple identities. And one way to bring this into your work may be through Pamela Hayes's model, the addressing model. And I'm not going to go through all of this, but you can see it sort of gives you some anchors, sort of ask about and dive into. And that in turn can help us do a more culturally sensitive assessment and then inform our treatment and help us infuse early psychosis work with more culturally sensitive tools, which we really need. And then on the right here is what I'm going to talk about over the rest of the presentation, which are the cornerstones of early stage psychosis work. And I'll talk about how we can infuse culture into all of these areas. Okay, next slide, please, Jenny. We're going to start with community engagement, outreach, and education. Wonderful. Great. So what these studies are basically showing here, first off, if you look at the graph on the right, is that as outreach increases, those are the squares in the graph, basically, giving presentations or having talks with people in the community about psychosis, unsurprisingly, referrals go up, right? So, I mean, that just highlights something, again, unsurprising. The more we talk about early psychosis, the more referrals we get, the more we identify people in the community who may need our care. Some of the messages that came from this research over the last decade or two have been around connecting with gatekeepers, right? So I'd encourage you all to think about, and some of you may have done this already, sort of like who are the gatekeepers in your community, right? Especially for recent immigrants. Are there local nonprofits or safe havens, right, that you can connect to if you want to enhance your cultural sensitivity, if you want to give a talk or have them give a talk or share tools? As I alluded to, we need to be aware of name recognition as well. If you're from a big medical center or university, That could hinder outreach, so we need to be aware of that and acknowledge potential, stigma that people may have and mistrust people may have due to past injustices or racism. And as always, we need to practice cultural humility, right? This is sort of the next iteration of cultural competence, which we don't usually talk about that much anymore. It's really cultural humility now, right? It's that we're always humble, that we're always learning more about cultural issues and being sensitive to cultural issues and acknowledging that we don't know everything, and it's a lifelong learning process, right? And as we'll see on the next slide, we also want to focus on different conceptions of psychosis in culturally diverse communities, right? And think about how that fits into how people think about psychosis, right? And we'll see that on the next slide. Go there, Jenny. So this is an example of someone who gave an outreach presentation and they were talking about psychosis, right? Which is sort of like, could be talking to spirits or hearing voices. And this was given to a Native American charter school. And the presenters were interrupted at one point and they were like, oh, it sounds like what you're describing is like a medicine person in my culture, right? So we really need to be sensitive to sort of how we describe psychosis and what the nature of it is. And what can be helpful is to find a common ground, right? This is the definition we have in our DSM, and we're always trying to improve that definition and be sensitive. But maybe we can agree that these experiences for some people, may lead to disruptions in their functioning, or may prevent them from doing things they want to do in their lives. The impact on their life may be a more important conversation to have. Can we go to the next slide, please, Jenny? And always person first language is important. So some of you may know this in the room already, but there's been a big push to use more and more of this in the mental health field. So we want to avoid derogatory or stereotypical concerns, related to this presentation. Schizophrenic, for example, we don't typically use that term anymore. We don't want to call someone schizophrenic. Rather, they're a person diagnosed with schizophrenia, or a person living with schizophrenia, or a person who has, voice hearing experiences. We want to humanize and frame the person as someone who has those experiences, but that's not all of who they are, right? They're not just schizophrenic. They're a person, a brother, a son, and someone who has experienced, let's say voices, for example. Okay, so language is very important in this work. I'm gonna go to the next slide, please, Jenny. Now we're going to get into one of my favorite parts of the presentation, which is screening and assessment. And again, as Ginny and Kelly mentioned, I encourage you to ask any questions throughout. I'm happy to answer them, but we'll probably have some time at the end too, if you want to ask them. So we'll go to the next slide, please, Jenny. Okay. So this is a systematic review of psychosis risk screening, and you can go forward twice, Jenny. Perfect. And basically what this review showed, and this was by two of my colleagues who used to work in Maryland, is that despite the wealth of evidence we have out there, linking the duration of untreated psychosis to, poor outcomes, most clinicians unfortunately don't utilize the early psychosis assessment screeners and tools that we have. Given the costs associated with training and administration, screeners, can be a really cost-effective way and an easy way for clinicians to, bring these. So we'll see a few of those. We'll go to the next slide, Jenny. So I'd encourage you to look into these two screeners, which are commonly used to assess for early psychosis experiences. They're freely available online. Those are two links you can look at. One is the PRIME screen. It's revised and it has items related to distress as well. And then we have the prodromal questionnaire developed at the University of California, San Francisco, which is a similar questionnaire. They're both pretty good, and that can be used to assess as well. And these are self-report screeners that you can easily bring out with a youth and or family, fill out, and then eventually, maybe specialized program in your state, which we'll talk about too. So next slide, please, Jenny. So let's look at the PRIME. We'll look at two example items here. So these are just 4 of the 12 items. So this is not all of them. And you'll see that people are asked to say if they've experienced any of these in the past year. And then if you could click the animation, Jenny, you'll see that we also then ask people, okay, if you, answered a 1 or more to this, so, if it's something that you've experienced, or even a 0, right? If it's something you've experienced. Do you feel frightened? Do you feel concerned? Does it cause problems, right? Because we want to know not only have you had experiences like this, but have they been causing distress? I'd also want to point out here, a developmental lens to have, because I have asked question 3 to youth before. I may have felt that there could possibly be something interrupting or controlling my thoughts, feelings, or actions. I was working with a 14-year-old girl, and she answered that, I think, at a 5. Some 3 said it was causing distress. So I was like, oh, okay. So I asked a follow-up question, like how that happens. And she said that, oh, like my mom controls everything I do, right? So that's not a psychotic experience. So that's sort of one of the limitations of these measures. We sometimes have to ask follow-up questions to sort of understand what's going on. And again, if you go to that link on the previous slide, you can find out more information about scoring and what this looks like. Okay, next slide, please, Jenny. And whenever we use these tools, we want to be aware of cultural considerations. So as I mentioned, age is a factor. We know on the PRIME screener that younger adolescents, I think who are 13 or younger, this tool doesn't tend to be as sensitive or valid. I'd still encourage you to use it as sort of like a screener and to gather information, but just be aware that the research says it's not as valid. And that's likely due to developmental issues, right? Kids, maybe in a fantasy, world sometimes, very developmentally appropriate, may answer questions like the kid I just mentioned answered. So you want to be careful with that. We also know that isn't as valid for Black youth as well. So we need to do more research in this area and be aware of that when we're using this with youth of color. And last but not least, we know that contextual factors play a role here. We know that people who have histories of community violence, so there's violence in their neighborhood, for example, they have higher scores on this. So again, we want to keep in mind context and ask questions about that. And research continues in this area. So you can go to the next slide, please, Jenny. And this is an example of the prodromal questionnaire, or the PQ-16. And you'll see similarly that people are asked true and false, right? If they have experienced something like this, right? I've been confused at times whether something I experienced was real or imaginary. Okay, if true, how much distress does this cause? And this is a really good tool as well. This is something we actually use in my clinic and that we've shared with various outpatient clinics at Mount Sinai. And if people score positively on the screen, I think it's 5 or 6 items endorsed, then they're referred to our specialized clinic. So again, this is a practical tool you could use today, next week, share with others, and may help to identify more folks who are at risk for psychosis or in the early stages of a psychotic disorder. Next slide, please, Jenny. Okay, and similarly, to the PRIME, we need a contextual lens here because it is currently unclear whether we need sort of different thresholds for different cultures. There may be cultural differences in terms of responding to this. So research continues in this area. But again, overall, I still recommend that you use these tools, but just have this cultural lens in mind and to be asking those questions that we've talked about. Okay, next slide, please, Jenny. So overall, more work needs to be done on culturally sensitive assessments for early psychosis. But there are a few things we can do, right? So as I've mentioned, consider culture and context. So allow time for the individual to discuss contextual factors, right? Neighborhood violence, histories of police victimization, acculturation, race-based stress, et cetera, et cetera. I think there's more we can do in the future to assess cultural competence and humility of clinicians, right? Bias that we may have. We need to assess for comorbidity as well. A lot of youth experiencing early psychosis also have anxiety and depression, right? So sometimes it's hard to disentangle is this anxiety, depression, psychosis, so more training around that is important. And as we've been discussing, it's been a theme of today, right? Culturally sensitive assessment and developmentally informed, right? So I know I'm preaching to the choir here. This is a group of people who works with youth, but we need to be really on top of the youth norm literature, right? So what is youth norm and developmentally appropriate versus, what's veering into maybe a psychotic experience that's sort of like outside the norm, outside of, let's say, youth self-consciousness, right? When does that become paranoia? So we need to be really good in both of these areas and acknowledge also, the dynamic nature that youth are growing, right? They're not sort of static, right? They're always moving forward and developing. Okay, so you can go to the next slide, please, Jenny. And this is another practical tool that you can bring into your work. Some of you may be familiar with this. This was developed by the American Psychiatric Association. It's freely available online. And actually on the right side, that's a picture. And if you go forward once more, Jenny, that's a link that people can go to free training in the cultural formulation interview. And this is a great tool. It's fantastic and unfortunately underutilized. But as you can see from some of the questions here, there are, I think, 16 questions overall. These were 3. It really helps dive into, a person's cultural experience and their definition of the problem, right? Sometimes I work with youth and families who don't agree with the term psychosis, maybe you want to call it something else, or see, the experiences as being caused by, something related to their spirituality or religion. So we really want to dive in and, make sure that we don't have any blind spots as clinicians, and make sure that our clients and patients feel heard and understood, right? So this, I think, is a great way to help us be aware of our own biases and dig into various areas. So I highly recommend bringing this into your work as well. It can be really illuminating in my experience. And we go to the next slide, please, Jenny. Now we're going to talk a little bit about treatment. And you may be thinking, and I've alluded to this, I think, a little bit, okay, I do this screener, I do this assessment, something seems off here, I need to talk to someone, I need consultation. I looked into, over the past week as I was preparing for this presentation, early psychosis programs in West Virginia, and it looks like Quiet Minds is a program, and they have a few clinics throughout West Virginia, and they focus on early psychosis. So that would be, I think, the first place I would recommend you go to. They may be able to offer some consultation to you, or you may be able to refer your client or patient and their family. I would also keep an eye on this map, which you can find at the 2 links below. And yes, Barbara, absolutely. I'll share this information so everyone has it. And that gives you a list of early psychosis programs across the United States. Again, for my research, I think Quiet Minds may be the only one or one of few in West Virginia, but that would be your go-to to refer folks. Okay. Next slide, please, Jenny. And with that said, if people have other information, because I know you all are much more familiar with West Virginia than me, feel free to put that in the chat for people as well. I can totally be ignorant around early psychosis in West Virginia. I'm still learning about it. In terms of schools, because I know this is very relevant for this conference, if one of your kids is at risk for psychosis or in the early stages, there are some great resources out there for you to look into. So there's an empirical article there on screening practices and what comes up among school providers. And then there's this really helpful white paper on the right about how to support students experiencing early psychosis in middle school and high school. And you'll see a few great recommendations in there, including potentially using IEPs or 504 plans, working with families to best support youth. So please look into that. It's really important to collaborate with schools. And that's why I'm so thrilled to present here today and work with so many people who are involved in the school system. And then next slide, please, Jenny. This is going to continue around school information. Just some sort of words of wisdom from that white paper. So communicating with students, families, and mental health providers is so important, right? So if an episode comes up, maintaining communication is going to be so important. Being approachable, right? I'm sure you all do that as school staff already. Maintaining consistent contact with students experiencing psychosis who may be feeling stigmatized or maybe afraid of these concerns, right? So keeping that open door, being there for them, maybe collaborating with a treatment provider and staying in contact, very important. If unfortunately, one of your kids needs to be hospitalized for an acute episode or they're having a tough time, having a plan to ease that transition and help them make up work can be really important. Available accommodations, as we've discussed. Again, and then the second last bullet point just highlights communication, right? Immediately having school-based professionals notified of an acute episode, ensuring safety for everyone. And then this last point is something that I'm really passionate about. Actually, my dissertation was on how to reduce mental health stigma in high schools. And as I've said, and as we've seen, stigma towards psychosis is still so significant. So, these are things that you can do now, right? Even if you're assessing and not finding anyone at risk or experiencing psychosis, You can bring in presenters, right? You can work with the National Alliance on Mental Illness, or you as the school staff can give a presentation on psychosis and myths. And that can really help reduce stigma. And, maybe for some kids who are having unusual experiences, may even make them feel more comfortable to reach out. So it can have some really powerful effects. Next slide, please, Jenny. And then revisit frameworks. And you could play this out a little more. I just want to draw the point that On Track New York, which is a program here where I live, this is the first episode Psychosis program, who I think has done a really good job of integrating culture into their work. So they have a whole manual dedicated to this, and you'll see a few themes they focus on and many more, right? So how does religion and spirituality intersect with your psychotic experiences? How does, your family culture intersect? Your, language barriers is a huge one. Sexuality, youth culture, right? Youth development, we need to be aware of that, right? How does that intersect with psychotic experiences? For example, your use of social media, or how much you want to disclose to people your mental health difficulties. So really important areas to look into. And I think On Track is a great example of a place doing that. Next slide, please, Jenny. And just some general treatment principles, which again, may be a reminder for folks, but I love talking about them. And I think it can be important to reiterate them. We always want to practice cultural humility, right? We want to ask about people's identities. I have found it so illuminating just being open about my own pronouns, right? When I share that with you, I use he, him, his. What are your pronouns? You don't know how many youth I've worked with whose eyes have just lit up, and they're like, "Oh, no one has asked me that before." So this is my gender identity. This is how I identify. And we know research shows that open discussions about cultural dynamics and identities, me being a white male provider, and talking about how that is, and if you've worked with a white or a male provider before, that leads to more positive therapeutic alliance, right? You kind of call out the elephant in the room, you acknowledge to the person that you're culturally aware in some way at least. And we know that clients and patients and families really respond to that, that openness and feeling comfortable to talk about their own identities and maybe their own reactions to you as a therapist. And as we've said, just some reiterations, really want to be aware of acculturation, respect cultural beliefs, and use that cultural formulation approach. You can go, I think, a little further. There might be 2 or 3 more. Yeah, perfect. Great, thanks, Jenny. Using a strengths-based approach is really important. Our youth have tremendous strengths and resilience, right? So we don't want to only focus on, the psychosis or, what is wrong or, how bad this could be, right? But, how do you cope? Like, what are the things you do really well? And then negotiating a shared understanding and finding common ground is a big one. And you'll see I have some information on allowing youth to explore their illness narrative from a great clinic in Australia to the cultural formulation interview, right? Like, okay, what do you call this problem? What do you expect to happen in the future? These can be really illuminating questions. Okay, go to the next slide, please, Jenny. And this is an example of finding common ground. So for example, I've worked with a Pakistani family who believed that the psychotic experiences that their child was experiencing were due to something related to Islam and like an evil force. So although that is different from my cultural beliefs and experiences, we were able to find common ground in that, okay, yeah, I respect your belief system, and maybe we can even connect to your faith, your mosque, maybe talk to a religious leader. And we can all agree that this is, impacting your child's functioning at school and at work, right? So really negotiating a shared understanding, showing empathy, and instilling hope, right? That, we have treatment that works. All of those things are so important. We can go to the next slide, please, Jenny. Great, it looks like we're good in time. We'll have some time for questions too. So I'm just going to breeze through this. This unfortunately highlights probably something, again, not surprising, that there are a lot of racial and ethnic disparities still in early psychosis care in the United States. Black patients overall having less access to care and more symptoms at baseline. Families of Hispanic participants being less likely to receive family psychoeducation. Families of non-Hispanic Black participants less likely as well to receive family psychoeducation. So really need to be aware of these continued disparities, and I think create bridges with these communities to, again, enhance access, enhance early intervention as much as possible. Go to the next slide, Jenny. And now we're going to go into research, just a quick slide for people who may be involved in research or connected to research in some way. There are some concrete things we can do. We can collect more basic transcultural data. You don't know how many research studies are out there that just don't collect basic information on race or ethnicity or language or place of birth or immigration. And again, interpreters and cultural formulations need to be embedded as well. Those will be super helpful to our work. And we also need to work upstream. So we need to target social risk factors in a very preventive way, right? So from early on, in terms of the school system and stigma and other factors around that can lead to psychosis. And you'll see England's great article there. She talks more about value-based care as well, and assessing and addressing social disadvantages as well. All right, we can go to the next slide, Jenny. And this will wrap us up. So summary and next steps, and then we'll have some time for questions. So overall, right, we see that psychosis and culture are deeply intertwined. We need a culturally sensitive approach whenever we work with youth in the early stages of psychosis and their families. We know that early stage psychosis intervention does work. It is effective. And we know that early stage psychosis intervention efforts will be most effective and equitable if they are culturally responsive and have this intersectional lens. It's just necessary. It needs to be part of our work. So next steps are related to this, right? Ensuring services are accessible and equitable, using these intersectionality lenses or the addressing lens of Hayes, using the cultural formulation interview, using these early psychosis screeners that we have, and continuing to develop them and refine them. Engaging in active self-reflection and cultural humility as clinicians, which you're all doing today, which is fantastic. And I think really importantly, actively recruiting and composing diverse treatment teams, right? Making sure that there are pipelines for people to get into these treatment teams and get to leadership roles and have these teams be more diversified. So we can go to the next slide, which I think is just for questions. And I'm happy to answer any questions people have, and I thank you all for your attention today.
Thank you so much, Dr. DeLuca. If we have any questions, if you guys could put those in the Q&A at this time. And thank you for bearing with us with all the technical stuff. It's the first day in the morning and everyone's new to this. So I think we survived. We made it through the first session. I also want to mention to everyone that Dr. DeLuca is going to be doing a burst session from 4:30 to 5 this afternoon to just go over just really quickly some of the things in summary that he's talked about here today. So if you want to check in between 4:30 and 5, we're going to be there talking more about this. And I really appreciate you sharing all this information. I think we are seeing a lot of this happening with our kids, and people don't necessarily recognize it for what it is, which makes it difficult. So I do thank you for this information. Are there any questions? I'm not seeing any questions. So as you will see in the chat, Dr. DeLuca has entered a link that you can go to check out stuff, and I believe you'll be providing us with your PowerPoint, correct? And that's okay for us to share. Okay, all right, very good.
We have about 7 minutes until the end of this session.
All right.
We have a 30-minute break between this.
If there are no more questions, then we'll sign off for now. Thank you so much, and our next session will start at 11:30, so that gives everybody a break to check our vendors out before moving on. So have a great day. Thank you again.
Thanks, you too.
All right, bye-bye.